Welcome to the Center for Interdisciplinary Health Workforce Studies, the Fall Webinar Series, which, as many of you know, is focusing on the rural healthcare workforce. We're really pleased that all of you are joining us for today's webinar. The Center is hosting 2 additional webinars as part of our fall series. The date of our next webinar is November 12th at 2 o'clock in the afternoon Eastern Time. That webinar will once again focus on rural health, and this time on the role of nurse practitioners. So while you have your calendars handy, please also mark December 10th at 2 o'clock Eastern Time. This will be the final webinar of our fall series, and here we will focus in on rural dental health care. But today's webinar is going to focus on physician's assistants. And before we begin the webinar, just a couple of points. We intend to allow for about 15 to 20 minutes of interaction with you, our audience, and with our 2 speakers once they have both concluded their presentation. Please feel free to type any questions you have in the area designated for questions, which is on the menu bar, and we will get back to as many of you as we can. We're also recording today's webinar, and we will have it posted on our website, which is at vanderbilt.edu/health workforce studies, period. You can find last month's September's webinar recording, which was about issues facing rural physicians, posted on our website in case you may have missed it. So today, again, we'll focus in on physician assistants as part of our rural healthcare workforce. The first presentation will be given by Dr. Jennifer Coombs. Now, I could spend quite a few minutes talking about Dr. Coombs, so I'm going to sort of give you some of the highlights. But Jennifer has been a PA for over 20 years, and she graduated from the University of Utah's Physician Assistant Program in 1991. She has a master's in Physician Assistant Studies and also a PhD in Public Health. Dr. Coombs began her clinical practice as a PA in family practice at Northwest Community Health Centers. She's practiced for over 10 years with a special emphasis in Vietnamese refugees. She has received numerous awards, but I call attention to the Humanitarian of the Year award given to her by the Utah Academy of Physicians Assistants, not once, but twice, once in 1992 and also again in 2006. She is on the board of directors of the Utah Academy of Physician Assistants, and she has served in the House of Delegates of the American Academy of Physicians Assistants. She is currently serving on the executive editorial board of the Journal of the American Academy of Physicians Assistants. Now, Jennifer's interests include rural and underserved healthcare, both in Utah and internationally. She's been involved in rural and clinic outreach missions, in medical missions to San Lucas, Talaman, Guatemala for 7 years, and she has a sustained interest in gender pay disparities and has been asked to speak locally and nationally on the issue of pay gap for women. So without any further delay, I'm going to turn the presentation over to Dr. Jennifer Coombs, who will present a brief history and the current assessment of rural PAs, their distribution and scope of PA practice, and issues facing retention of the rural PA workforce. Jennifer, thank you very much for being a speaker today. We're delighted to have you, and you now have the floor.
Okay, hi, this is Jennifer Coombs, and I'm going to try to get the thing to show my screen here. So, it says I've been made the presenter, and then I am trying to get my mouse to work. Well, I'm not even using my mouse, I'm trying to get my... I'm going to try escaping. Ah, I got it. Show screen. There we go.
We see you, Jennifer.
All right, so now you can see, right? My first slide. Okay, so I'm going to start with a fun picture. I'll have a few pictures of Utah. Not going to talk only about Utah, but I'll use Utah sort of as an illustration for a little bit of what's going on for PAs in the West. And then Chris Everett, who's also going to be speaking, she'll be speaking after me, and I think it's kind of a nice setup because she's in North Carolina. So we'll kind of talk a little bit about what's going on from both sides of the country. So basically, I'm going to give you an overview of the world workforce and talk so briefly about physician shortages, because I think we all know that there are physician shortages in rural areas. And then, as he said, a brief history and overview of PAs and a current assessment of what's happening. Now, this is sort of my list. This is, kind of this idea that there is a crisis in rural America, and I've been lucky enough to get to travel throughout the West and visit some of the PAs that are practicing in rural towns. I've had these really wonderful, unique experiences over the last couple of years. So this is my list. Small town Utah has a lot of elderly. There's some economic stagnation. It's some sort of kind of ominous to say towns without young people, but basically that's part of the economic stagnation that you might see. I visited a town in Nevada where basically the only two kinds of jobs were working in the casinos or working in the mines. And you just definitely did not see a lot of young people. You also then, of course, have sustainable chronic disease. Native American populations, which I think is unique to the high desert area, the plains states, Oklahoma. But I certainly have been fortunate enough to visit the Navajo Reservation, which is just a huge landmass. And I don't mean that there's a crisis that we have Native American populations, but just to note that these are very special populations. And then, of course, health profession shortages. So let's talk about PAs really quickly. 84,000 licensed PAs in the U.S. Oops. Program growth is big. And one of the important factors is that program growth of PA programs is primarily at private institutions. I'm going to talk about debt as an issue for PAs and how they are able to go out and work in rural areas if they are holding a great deal of debt. The projections are 125,000 PAs by 2026. Interestingly, very young profession. That's good. Primarily white and primarily female. The median compensation, this is just all across the board. We're going to round it up to about $90,000. A brief history of PAs in rural areas. Basically, since the whole concept of PAs started, it was designed for providers to go into rural areas. The most common practice for a rural PA is primary care. You see rural PAs in community health centers, migrant health centers, Indian health centers, and prison systems. One study showed more than 50% of rural hospitals utilized PAs. I like this picture of these two guys when I visited them in Enterprise, Utah. These are two PAs. They were both wearing their jeans when I went and visited them. They look pretty cash. They're really great providers, very valued in their community. They look like they're ready to go out and hang out at the diner, so they're young and very excited about working in their communities. You see that we have 62 million Americans, or 20% of the nation's population, that live in a rural area. And of course, only 9% of the nation's physicians practice in rural areas. 77% of the 2,000 or so rural counties in America are designated as health profession shortage areas. And then of interest, I think, is that PAs and NPs together now outnumber family medicine physicians. Here shows the physician maldistribution. I think everyone who's familiar will know this map. And it shows, I think, a very interesting pattern. Again, you can see out west, there's some real shortage areas and little pockets of really just quite lack of providers. This is a picture of Ravina Thakur. She's a PA who works in Monument Valley, and I was able to visit her. She and her husband, she's a PA, she and her husband, Fred Tucker, and then this is a Representative Matheson, our congressman. They're both, Ravina and Fred are both veterans. She speaks to her patients in Navajo, and it's just a very unique, wonderful practice that she has. She's in a community health center. So again, Utah, it's a pretty great place, we like to say. It looks very, the red is urban, and you just have this kind of typical pattern. This is true in a lot of states where you have this highly dense urban area that's just a tiny little area, and then the rest you have vast rural and frontier counties. And I think one thing was, when I look at this, I see all that green out there. That green doesn't mean there's little farms or towns. Like, maybe I grew up in Wisconsin, maybe you'd have this real rural towns outside of your urban cores. But I think in Utah you'd find these are vast counties that don't even have paved roads. So there's some real areas of remoteness out there. And then this is my little map that I made of the PAs and how they are distributed, again, primarily in these urban areas, but definitely some PAs dotted throughout some of the more rural areas. And it also is interesting, and I think one thing that we could talk a lot about, but is the highway system in the West. So you're going to see these little, if I put the highways over here, a highway overlay, you would see, the I-15 corridor kind of extending down, and then there's a little cluster down there in southern Utah, which is the road to Las Vegas. So again, it kind of depends on, where the highways are, and there's a lot to be said for being close to an interstate. This is, some people think that it's looks like the Mars lunar landing. So I just wanted to sort of show this as a picture of again, we were talking about incredibly remote areas. So PA distribution, there's a higher earning potential in urban areas. Affordable Care Act, we think, may benefit rural states like Utah, but in Utah, we're still debating Medicaid expansion, for example. You, of course, need a workforce to deliver that care, and then reimbursement of PAs by Medicaid, and especially Medicare, is really maybe a greater issue in rural areas because elderly populations may be as high as 45% in some rural areas. As I discussed, that's one of the issues. The percentage of primary care physicians and NPs, PAs and NPs varied by the urbanicity of the physician. PAs and NPs are more prevalent in rural and underserved areas, which have fewer primary care physicians. The supply and access to physician increases as PAs are more urban, and the inclusion of PAs or NPs in primary care practices increased as office locations became more. I can't see the side of my slide there, but there's been some studies that have shown basically PAs and NPs do become more prevalent as rurality increases. Okay, let's talk about PA state laws. The American Academy of PAs is very interested in having all states have these 6 key elements of a practice of their state practice act. And they are here. Licensure is a regulatory term, scope of practice determined at the practice site, adaptable supervision requirements, full prescriptive authority, and the number of PAs a physician may supervise determined at the practice level. Chart co-signature requirements determined also at the practice level. And I called or emailed one of my friends that lives in Kentucky. They recently had gotten their a couple of things on their wish list. And so this is just an example of sort of some recent changes in which PA practice acts are being curated a little bit more towards a less restrictive environment. And these are, you know, they were really excited about these changes. And these may be very, very important changes that will help PAs to go out into rural areas if some of these small items are eliminated, and it makes it a little bit easier for people to practice remotely. I mean, they were very excited about decreased co-signatures for charts. So Kentucky is also one of 2 states that cannot prescribe, where PAs cannot prescribe narcotics, and I thought that was interesting. Now this is a really nice map. So we see these 6 key elements and where in the country PAs enjoy these either more restrictive or less restrictive practice acts. And one of the things that I think you can see from this slide is it's kind of all over the map. We have more restrictive environments, kind of perhaps in, you know, we've got Kentucky and then, you know, kind of, and then Oklahoma, but they're right, it's right next to a perhaps a less restrictive state like Texas. So you have these kind of, it's really interesting, especially in the Midwest, how there's states right next to each other that have very different practice environments. And then here's just some examples. 24 states require a physician to sign a certain percentage of the charge. And most states do specify how many PAs can a physician can supervise. And generally it's in the number of from, you know, either 2 to 6. Utah recently went from 2 to 4. So you can see that there's some small but potentially important changes that are occurring. So Dr. Everett's going to talk a little bit more about kind of how this looks out there. So some states place restrictions on how physicians must be on site, and I think that's something that hopefully we'll see some changes in terms of that, and maybe a little bit of some loosening in terms of the some of the restrictions that are out there. Yes, there is a considerable cross-state variability, as I was saying, and then Dr. Everett and I were talking, and she ran an analysis to see if there was a correlation between the practice environment of the state and either more or less restrictive laws and the rurality, and it was no surprise to us that really there's no correlation. And basically, there's been many studies that have shown that NPs, PAs, and certified nurse midwives increase access in rural areas. And, you know, just a couple of different studies that have shown this. Expansion there's some state workforce commissions that have recommended new and expanded programs. And as I said, new programs are expanding at private institutions at a higher rate. And so we're a little bit worried about debt load. So I'm going to talk about debt. Loan repayment is out there. It's primarily at the federal level. It's really the big player here is National Health Service Corps. Few states offer any kind of debt relief. And basically, as far as any other public funding for PA programs, that usually comes through the feds, which is the HRSA. So debt, let's just talk, I'm going to talk a little bit more about debt because it's so important. And basically, let's see, physicians, it's $170,000 in average debt. So that's just to kind of put it in perspective, and you can kind of compare and see how you feel about the PA debt that's out there. So recently there was a Robert Graham Center report, and a quarter of PA students are carrying over $100,000 in debt. Another quarter, it's 50 to 100,000. So, it's kind of interesting, the debt that's out there. That's a lot of debt. And then there's some surprising findings. Basically, students at both ends of the debt spectrum were likely to go or express interest in practicing in a rural area. So I just thought that was kind of a surprising finding. So that's just something that I think is worth noting. Now, here's another issue: PAs who own their own practices. A lot of people will say, how does a PA employ their supervising physician? How does that work? And many states individually determine if this is okay, and then I have kind of a list of there's information in the American Academy of Physician Assistants, which is actually a very good, they have a lot of information. And basically, you set up your practice so that you have a relationship with your supervising physician, and then a corporation or some other entity is paying the physician. There's a lot of ways that this can work out so that the business and the medicine are sort of separate. And it's definitely something that, for example, in Idaho, recently they found out that I think it was about 10 practices own their own, 10 PAs own their own practice. And it's definitely something that it does happen, and I think it's an important way that PAs can get can expand access. One of the things is there was a story of a PA and a physician working together, and the physician unfortunately died of a stroke. Well, the PA ended up buying the practice. So it is kind of important that that PAs and nurse practitioners are able to own their own practices, and it can happen. There was a recent National Governors Association report basically calling for states to ensure that their licensing laws and regulations were using appropriate language, and basically that there was also clinical training opportunities for PAs, which has been a big issue. And then also this idea of creating financial incentives at the state level to help PAs to get out into rural and underserved communities. I think one thing that's very true of PAs is there's a fair number of PAs that they're willing and eager to work in rural areas. So we have to kind of look at how our policies and some of the things that are going on can make a good alignment of where people want to be and what they're allowed to do. And then got a picture of a real PA. So we know that PAs provide cost-effective medical services to underserved areas. It is probable that rural PAs do practice a larger scope of practice than urban PAs, but it is probably necessary to be able to match the large problems and needs of rural populations. We have critical access hospitals out there, and it's great that there's language under the Medicare conditions of participation that says that specifically that nurse practitioners and PAs can be reimbursed. And then also I want to just include some resources. Basically, the ruralcenter.org has some information about hiring a PA and how to get the contract and the compensation package to be in alignment. Another picture, I actually like this one. I like this picture because there's a little road going along here, and I've been on that road, and it's a very long, remote road. And my references. So now I'm going to hand it over to you guys, and we'll let Dr. Everett talk.
Thank you very much, Jennifer. I appreciate your great introduction, and your pictures of Utah made me long for another visit to that state. It's a beautiful, beautiful state. Again, thank you very much. And it's a great setup for our next presenter, Dr. Christine Everett. Now, Chris joined the faculty of the Department of Community and Family Medicine in August 2013, and this was at Duke University. Now, prior to joining the faculty, Chris worked clinically in emergency departments in rural Wisconsin. And prior to becoming a physician assistant, she had worked in research at the National Institutes of Health and Public Health Policy at the Food and Drug Administration. Dr. Everett's research initiatives have focused on healthcare team design and the impact on patient, provider, and organizational outcomes. Some of her recent work has focused on understanding the role of primary care physician's assistants and primary care nurse practitioners and how they relate to outcomes for patients with diabetes. Christine, you will find publications of hers in a variety of journals, including the Journal of Rural Health and in the Journal of Medical Care Research and Review. She recently completed the first comparative effectiveness study of primary care PAs and NPs, which was published in the Health Affairs Workforce Special Issue, published in November of 2013. So today, Dr. Christine Everett is presenting new research highlighting the role of physician assistants in rural settings and their impact on cost, quality of care, and access in underserved areas. Christine, thank you again for joining us. It's all yours. Take it away.
Wonderful. Thank you. It's my pleasure. So hopefully this won't take very long here. Can everybody see the slide presentation? Is the slide presentation visible, Christy? I hope so.
We see them.
Yep.
Okay, perfect. So again, thank you for inviting me. I'm excited to talk to you today about rural physician assistants and their roles, as well as their impact on cost, quality, and access. So what I'm going to talk to you a little bit today is about what we know and what we don't know about rural PA roles, and again, the impact of these rural PAs. So I'm going to, it's not comprehensive, I'll highlight probably the most instrumental and the most recent studies, and I'll talk a little bit in two places about a recent study that I've completed that's actually just going to be submitted for publication. So, what do we know about rural PA roles and how we define them? Well, with the increased demand for services, particularly in rural areas, and the decreased supply of physicians, the way we really think about PA roles can vary. And it varies, I think, depending on who you are and the question that you're trying to answer. But the common ways that have previously, really been used to define roles are things like practice, specialty, and type. And again, as Dr. Coombs mentioned, the most common rural practices are primary care, and so we'll really focus on that today. But other issues that have come up in defining PA roles are supervision or physician involvement, the types of clinical tasks that PAs perform, the characteristics of the patients that they see, and the level of substitution. In primary care, substitution is most oftenly viewed as being a primary care provider or a usual provider of care. So after I talk a little bit about the research that's out there on those particular topics, I'll talk a little bit about a new way that I think about PA roles. So defining PA roles, as I mentioned to you before, primary care really is the most common setting that rural PAs work in this country. However, they are also utilized in hospitals, as Dr. Pims mentioned. 53% of rural hospitals utilize PAs. And the interesting thing, and that was a study that was basically done as interviews with rural hospital administrators in 8 states, and they described how PAs are used in those hospitals. They're used in emergency departments, in surgery, and in inpatient. However, rural hospitals, and particularly those associated with rural health clinics, were using PAs really to expand their outpatient services. And so leads me to, another study that was done by King that used the National Hospital Ambulatory Medical Care Survey and looked at how rural hospitals use PAs and nurse practitioners in their outpatient departments. And as you can see from the figure below, that much more in non-metropolitan areas, much more frequent to use PAs and nurse practitioners. So in the outpatient setting, of course, PAs are also really important in primary care, frequently used in community health centers and rural clinics, which are major sites for primary care in rural areas. The first table that you'll see here is from a study that was recently completed by Perry Morgan and Esther Hang and I that looked at the National Ambulatory Medical Care data, particularly in the community health center sample. And what it shows is, yes.
I'm sorry, I hate to interrupt you, but we're seeing like a black bar on the right-hand side of the slide. Maybe try starting your slideshow again, and maybe it'll go away. It's blocking a little bit of some of the text on the right-hand side of your slideshow.
Sure. Let's restart it. Let's see. Is that better?
Well, I still see it. I'm not sure why it's doing that.
Is that better?
That is much better. Yes, thank you.
I think it was the bar from the Go to My Webinar that was blocking it.
Ah, yes, perfect. Much better. Thank you. Sorry about that.
No worries. Let's go back to where we were. So here we are again, looking at the study that was completed by Perry Morgan and Esther Hang and I, and essentially looking at the CHC data from the NAMC data set. And what it really shows here, if you look at the difference between the percentage of visits that were performed in different metropolitan statistical areas, that PAs have the highest proportion of their visits in the rural areas. Another really nice study that was recently done and published in Medical Care was a survey of rural health providers in 13 states. And what that really nice piece of work demonstrated was that most commonly, 34% of rural primary care PAs report working in rural health clinics. So those sites are really key to PA participation in rural primary care. Another study, if you look at the figure down here below, was done recently in 2013 that looked specifically at rural health centers nationally and disturbingly demonstrated, however, that PAs may be decreasing in their staffing of rural health centers. So the second way that we think about defining PA roles is really the level of supervision or physician involvement in the care that they provide. And unfortunately, we have a really limited amount of information on this, and the information that we do have really is mostly in these proxy measures. So what do I mean by that? So one of the proxy measures that we've used was used in a study done of a survey of medics graduates, where they looked at the numbers of hours per week that the PA was in the same building as their supervising physician. And what they found was that rural PAs have slightly fewer hours in the same building as their supervising physician. And so really suggesting that urban PAs may have less supervision. Oops, sorry about that. The other issue The other proxy measure that we have, of course, is that what Dr. Coombs had already mentioned, was that some states don't have mile limits on on-site requirements for supervision of PAs, and those numbers are decreasing. Currently, as of December 2013, 24 states do not have such restrictions. So the third way that we really think about defining roles is the tasks that they can perform. And Henry and Hooker did a really nice literature review of the contribution of rural PAs to primary care, and have a very complete list of the studies that have asked questions regarding the tasks performed. And ultimately, you know, the conclusions are that PAs do perform really the full range of tasks within primary care. One study that I really would like to highlight, though, was again that 2014 study that was published in Medical Care. That was a survey of rural primary care providers, of physicians, nurse practitioners, and PAs. And I really liked the fact that they not only looked at particular types of office visits, but they also included other primary care tasks that frequently get performed but often overlooked. Ultimately, that study, what it determined was PAs are really pretty similar to physicians in the types of tasks that they perform, with a few exceptions. When physicians more frequently perform well-child visits, which you will see in the table below, they are also more likely to have after-hours call coverage, as well as coverage in hospitals, emergency departments, and nursing homes, and they're more likely to attend deliveries. So patient characteristics. So what are the patient characteristics of patients that PAs see in rural populations? In general, the data suggests that PAs see patients that are quite similar to physicians. There are a few exceptions. Again, the study that I just mentioned that had been published in Medical Care, that was a survey of rural primary care practitioners, essentially said that PAs see similar percentage of Medicare patients, but a greater percentage of Medicaid patients than physicians. And again, the study that was completed by Morgan that really looked at the community health center patients in particular, age, gender, race, ethnicity, other demographic factors of the patients seen by PAs is really quite similar to those seen by physicians. The other way, and really probably the most classic way that we think about roles for PAs at all, period, but particularly in rural situations, are whether or not they act as substitutes. And as I mentioned previously, what that really means is, do they act as usual providers of care in a similar fashion that a physician would, versus acting as a complement or a supplement, meaning they provide some fraction of care. And there are a few studies that looked at that. One study was done in 2000, which was a census of PAs licensed in the state of Pennsylvania. And that particular study really showed that rural PAs within that state were reporting that they were the principal provider or usual provider for a higher proportion of their patients than the urban PAs. Another study that I did actually looked at a cohort of older patients in Wisconsin, also demonstrated that these older patients that reported having a PA as a usual provider were much more likely to live in rural areas. And then this third study, again, was a study done by Morgan using that CHC data, which really demonstrated that the percent of visits with usual providers, where the usual provider performed the visit, was higher for PAs at the rural locations of CHCs. So again, really suggesting that rural PAs are much more likely to act in that role. So here's some data of that newer study that I wanted to mention to you, a study that I recently completed and submitting for publication, which utilizes the Household Health Tracking Study survey data, which formerly was a part of what was called the Community Health Tracking Study. And the survey sample for that is representative of national non-institutionalized civilians within the United States. And the sample that we looked at from that survey were folks who reported having a usual place of care that was a primary care clinic, a usual provider of care that was a primary care provider, meaning a primary care physician, a PA, or a nurse practitioner, and had at least one primary care visit within the year. And so what I tried to do was actually combine several ideas that we previously talked about, because while we can get an idea of roles based on those factors individually, what I'm really seeing is that when you combine some of those factors, you see quite a different picture. So what I did was I divided people into whether or not they reported having physician-only care, whether or not they reported having a physician as a usual provider but had a PA or an advanced practice nurse visit within the year, and then those who reported having a PA or an advanced practice nurse as a usual provider. And what you'll see is that the characteristics of the patients really differ. I'm not going to go through these things in their entirety. However, just to give you the overall flavor for what these results really show, is that the folks that are reporting having a PA or a nurse practitioner as a usual provider are much more likely to be in rural, of course. But the other characteristics, most of them are pretty similar to physician with a few exceptions. One is that these folks tend to be younger. They tend to be a higher proportion female. And they also have a tendency to put off medical care a little bit longer. And finally, they report being healthier, which is in contrast to the folks who report having a physician as a usual provider. However, they have a PA or a nurse involved in their care, meaning that their PA or advanced practice nurse are acting as a supplement or a complement. And so what you see there is really quite an interesting difference. While they are still younger, are still more likely to be in rural areas, are still likely to be female, they have really different attitudes towards utilization. So these are the folks who are much more likely to go to a doctor very quickly. So they report being more likely to go to the doctor as soon as they feel bad, or if they disagree with the statement that they would avoid a doctor's visit. And they also report having worse health. So really a very different patient population depending on the role. So what these findings and other findings suggest to me is that the way we really need to be thinking about roles in the future is really a combination of all of those factors. And so the first way that I've looked at roles in the past is really to think about those factors in primary care that combine to define how work is divided between clinicians. So level of involvement, are they acting as a substitute or not, the types of patients they serve, and the tasks that they perform. But the next step that we really have to take is really looking at the dependencies between team members. So how closely do physicians and PAs work together? And there is no work on that as of yet, but hopefully soon. So let's talk a few minutes about the impact of rural PAs. And again, I'm going to try to go through this reasonably quickly so that we've got some time to discuss at the end. If anybody has questions, I'm happy to discuss it. And I also have a complete list of references at the end. But let's talk a little bit about cost first. So this particular study was a study that was done by Hooker in 2002. And it was a study that he used electronic health records really to see look at the differences of the cost of an episode of care between PAs and physicians. And it's not specific to rural settings, but I think it sets the tone nicely for what we're talking about. And essentially what it's saying is that for these different diagnostic categories, for bronchitis, tendinitis, otitis media, and urinary tract infection, that the cost of the care delivered by a PA and a physician are quite similar, and sometimes they're actually lower for PAs. So PAs have also been demonstrated to have economic benefits to practices. So this particular study I cite often, I like it a lot. It was a study that was done in 2002 where the investigator basically went into a practice, a single practice in Pennsylvania, a small town that's outside of Pittsburgh, and really wanted to evaluate the economic benefit of the PA in that particular practice. And what they determined was that PAs were doing similar tasks as the supervising physician. Their task substitution ratio was 0.86, with 1 being perfect substitution. But they also found out that the compensation to production ratio for PA in family practice is 0.36. So what that really means is that the PA is making money for the practice. They get paid 36 cents for every dollar that they bring into that practice. And they did lots of different sensitivity analyses, and I encourage you to read it if you get the chance. But one of my favorite tables that I have from that particular study is that they really estimated and took out how much more money a practice could make if they added additional PAs. So if they added 3 additional PAs, the number of annual visits would go up, and those PAs could make that practice almost $250,000 more a year, really demonstrating the economic benefit. So another really great study that was just published by the National Center for Rural Health Works tried to estimate the economic benefit of rural primary care PAs and nurse practitioners, actually, not only to the employing clinic, but to the hospital and the community in general. I really highly recommend this as well for anybody who's interested in demonstrating or estimating economic benefit. What's really great about this particular paper is that they provide a tool so that you can do that for your own individual situation. But essentially what this is saying, they estimated 4 different scenarios for incorporating PAs or nurse practitioners into a primary care clinic in a rural area, really based on the scope, reasonable scope of practice and the variation within states, as well as different FTE estimations that different organizations have given, so the comparison of the FTE from a PA or nurse practitioner to a physician. And so essentially the first 3 scenarios here they call collaborative practice. So the PA or the nurse practitioner would be working in conjunction with a physician. They would have clinic and hospital responsibilities, but with varying proportions of patient volume. So the first is 40%, the second would be 50% FTE, and the third would be a 75%. The final scenario is the NP working independently, clinic only, no hospital privileges, at 75% FTE of a physician. And so what you're really seeing is that the incorporation in any scenario, of course, increases employment. So what these numbers are saying is that anywhere from 3.3 to 13.4 additional jobs are created within the clinic or hospital with the employment of a single PA or nurse practitioner in a primary care clinic. And similarly, it's talking about the labor income that's generated from all those jobs within the clinic and hospitals, which you can also see is quite significant. The final 2 columns add the addition of the employment increase and the labor income increase in the community at large. And as you can see, varies greatly, anywhere from 4.4 to 18.5. And the one thing that I'd like to point out is that in their estimation, what appears to be the best deal, the best economic benefit, would be those collaborative roles for PAs and NPs, where you have very efficient utilization of those professionals. So let's talk a little bit about access and quality. It's a really nice study that was completed, which was a cross-sectional study that looked at the primary care supply, all primary care providers, as well as PA and nurse practitioner providers. I apologize for that pop-up. In Nebraska counties, and then looking at the ambulatory care sensitive hospitalization rates within those counties. For those of you who aren't familiar, ambulatory care sensitive conditions are those conditions where if you're providing appropriate primary care, it really reduces the need for hospitalizations due to those conditions. There are things like diabetes and asthma as examples. And so what this study really showed was that rural counties have significantly higher rates of ambulatory care sensitive hospitalization for pediatric and adult populations in particular, surprisingly not for geriatric. But the message of the paper, which I found interesting, was that it's the total primary care clinician supply that really impacts ambulatory care sensitive hospitalization rate, but not specifically the PA and NP supply. So other studies that have been completed that look at access and quality, certainly one that I had completed earlier again on that cohort of folks in Wisconsin. And so these are folks who reported having a PA or a nurse as a usual provider of care. And some of their outcomes related to access and quality were interesting. These folks reported that they had lower perceived access, as well as some decreased access in a few types of services, including complete health exams and mammograms, these preventative care type services. However, they did have some increases in other things like chiropractic visits. These folks reported similar self-rated health, so their health did not appear to decline more. However, they had similar difficulties and delays in care as those who reported having physician-only care. This, again, I'm taking you back to the recent study that I've done, again, looking at the household health tracking survey data, where we tried to look at PAs and advanced practice nurses in their two particular roles and look at some of the outcomes associated with it. We have several access outcomes as well as a couple quality outcomes. And again, you see some very interesting patterns. I'll remind you again, both of these roles were more common or more commonly reported by people who were in rural areas, so it certainly directly relates. But what you're really seeing, very interesting, is both roles really increase the utilization of primary care. So folks who report having PAs or advanced practice nurses in either one of these roles report utilizing primary care more frequently, even more so for usual providers than for those who are supplemental providers to care. However, that's pretty much where the distinctions are, that's pretty much where the similarities end, and you see some distinctions. So when PAs act or nurses act as usual providers of care, the rest of the outcomes are quite similar to physician-only care. There's really no other differences. However, when they act as supplemental providers of care, you start seeing some distinct differences. You see much more likely to utilize emergency departments more frequently, and more likely to report that they're dissatisfied with their care. So in summary, PA roles can be defined in a variety of ways. The usual provider is really the common way of thinking about it, particularly in rural areas. We have new ways to think about roles to incorporate multiple factors. Primary care PAs have beneficial economic impacts on rural areas, and the limited evidence available suggests that primary care PAs can improve access, but the impact on quality is varied. And then the references for the studies that I mentioned. All right. I'm ready to turn this back over. There we go.
Thank you very much, Christine. We have a few minutes remaining, but I want to just note we're getting a little bit of a technical signal that says we may only have a minute left on this webinar, and so if we should suddenly shut down, we apologize. We're just having a little bit potential technical issue on this end, but hopefully we have yet a few more minutes for some questions and answers. What I'd like to do is turn this over to Christine Friedman, who is the program manager of our Center for Interdisciplinary Health Workforce Studies. Christy has been monitoring the questions that are coming in. Christy, I'll let you take it away and guide us through this last part of the webinar.
Sure, great. Thanks everyone for attending. And I have this first question for both presenters. So maybe Jennifer, if you want to go first, and then Christine. How, in your opinion, or from what you've seen in your studies and research, how did the ACA impact the physician assistant workforce, both maybe at the onset and then, we're a year in, so kind of where are we now, and then how do you feel about the impact going into the future? Let's see. I may have muted. Let me unmute Jennifer there.
Okay, we're unmuting you, Jennifer.
Okay, sorry about that, Jennifer.
Okay, yep, I'm unmuted now. So, it's a story that still remains to be told. So, the first thing is this Medicaid expansion deal, which has just been like, bruising out here out west. The Utah governor keeps trying to come up with some sort of, calling it a Utah solution, not sure if this will be accepted. So, and political futures have been dashed because some of these, in some of these Republican states, they do not want to be seen, going along with the Affordable Care Act in any way, shape, or form. So there's a lot of that's going on. As far as like the provisions in the Affordable Care Act, which might allow, better reimbursement for at rural health clinics, those have all been very, very positive, and I think we'll ultimately see a positive impact if workers, and we're thinking, casino workers, ranch hands, this is kind of talking about this sort of economic stagnation. If those workers are able to go out into the exchange and get health insurance, it's going to have a positive impact. and maybe we'll even see some more of those dollars circulate even more. So with that study that says, hey, you hire a PA or nurse practitioner, that person stays in the community, then those dollars that are coming in from the federal government in the form of a, Medicare, Medicaid, that, or perhaps now the health being insured on the exchange, then stay in the community and are cycled through average of 4 times. So, I think we're going to see some good positive impacts. I think we'll continue to see problems in getting people to go to the rural areas and stay in them because of, issues of, how much money people are being paid, and obviously they're going to go to urban areas. But I think there's a lot of hope because nurse practitioners and PAs often come from those communities. They're eager to go back into those communities. So I think that the future is bright.
Thank you, Jennifer. Christine, do you have anything to add to that question?
No, I think I would just probably, if I was going to say it very succinctly, is that clearly ACA is going to increase demand for services, which is always good for PAs. The question will become the supply, whether or not we can keep up. And certainly we're increasing the number of programs, but even that, as Dr. Coombs pointed out, guaranteeing even if we create more PAs that they'll be willing to go to rural areas will be the million-dollar question.
Okay. Great. That's a great perspective. We have one other question in the interest of time. I know there's a couple more, but we might just get to this one. In Minnesota, we've heard that PAs are specializing more. According to the NCCPA, only 27.7% are practicing in primary care nationally, and specifically in Minnesota, 67% of PAs reported practicing non-primary care. Is the role of the PA truly becoming more specialized in healthcare, or are PAs defining themselves as specialized based on their practice facility or setting, yet still providing primary care to patients visiting specialist physicians?
That's a very good question. And, it's always interesting to me because there's always, if you look at, absolute numbers, because of the growth of the profession, we've got more PAs working in primary care than we've ever had before. So it's just interesting because as a percentage of the total number of providers, we actually have, for PAs and nurse practitioners, it's practicing in primary care, there's more than physicians. So, it's always kind of like, well, I think the death blow of PAs providing primary care it's just not there. It's the most common specialty for PAs is family medicine. So I'll let Chris take a stab at it.
Yeah, sure. No, you're absolutely correct. The number of PAs in primary care is going down nationally. And the question now becomes why. So that's the first part of your question. And actually, anecdotally, I can tell you from the 2 PA programs that I worked in, talking to new graduates, it's interesting because we go out of our way. There's many PA programs that go out of their way to try to recruit folks who want to be primary care providers, in particular primary care providers in rural areas. So we recruit these folks, they want to get jobs, and then at the end of the day, they're reporting to us that they can't find places, primary care practices that will take a new graduate. So we've done some initial work in North Carolina that certainly supports that idea. And now we're really proposing and trying to get off the ground to look nationally at whether or not there are job listings in primary care that are willing to accept PAs that are new graduates. So we're hoping to kind of get part of that. Part of that might be, the issue of really availability of jobs. So the second piece that you were asking was whether or not PAs in specialties are delivering primary care services. And certainly I can tell you that there's data out there that suggests that's true for physicians. There's a couple studies that if you're interested, I can certainly put my fingers on again and send to you that really demonstrate that even specialist physicians do provide primary care services. And there was one, and there are a couple examples, a couple case studies that are certainly published about PAs, particularly in oncology. If you, in examples that I'm thinking about off the top of my head are those in sort of the comprehensive cancer centers, where they're actually, some of them are starting to hire primary care PAs that deliver primary care to folks actually while they're getting their chemo. So I think that might be on the rise as well. Particularly if the whole idea of accountable care organizations really take off.
Well, certainly, just loan repayment, which I talked about, is a big thing. And then also, as I talked about, the state regulations. So those two things could go a long way in helping PAs to go into the areas that I think they're eager to go into. We definitely see, like you said, that graduates they want to go into some of these practices. So I think there's just an alignment of some of the policies would really go a long way to helping PAs to do that.
All right. Well, thank you. We're going to have to bring this webinar to close, and I would like to again acknowledge and thank Christine Friedman here at the center, as well as our speakers, Jennifer Coombs and Christine Everett. And in saying goodbye, we will hear each other again on November 12th at 2 o'clock Eastern Time, where our focus will be on rural health and the nurse practitioner. All right. Thanks very much.
Wonderful. Thank you.
Bye-bye.